So if we compare the overall etiology and the pathophysiology of both boys and girls, we will understand that delayed puberty is much more common in boys, but the likelihood of pathology is lower. So we need to be very careful in terms of not doing unnecessary workup in these scenarios because that can cause more confusion. So this was a 13-and-a-half-year-old boy with delayed puberty who was referred with a testicular volume of just 3 ml and pubic hair stage 1. So parents were concerned that there is delayed puberty. He was relatively short for the family with a normal weight. On investigations, he had undetectable LH and testosterone. Now, based upon this, the treating physician made a diagnosis of hypogonadotropic hypogonadism and advised a MRI head. Now, this was a very troublesome situation because parents were really concerned about not only the short term, but also in terms of the long-term future of the child and also whether there could be a pathological cause in that perspective or not. Now, if we can look at this case very carefully, we'll see that this is too early a age to evaluate for delayed puberty. He is probably going in more like a constitutional delay of puberty and growth, if at all anything. So this child should not have been worked up at all in this scenario. So I think this gives us an idea as to how so many cases where workup is not done, we are unnecessarily causing confusion in terms of evaluation. Contrary to that, we had the 16-year-old boy who presented with pubertal concern, who had an onset at 13 years. So puberty had started and then it stopped for 2-year period. At that point of time, when the child was seen by a physician, it was found that he had a testicular volume of 3 ml, which was soft. He had pubic hair development, which was a proof that there was a development to start off, and now the development has stopped. He was reasonably tall, and then he was labeled as constitutional delay of puberty and growth from that perspective. So this case scenario, in fact, if you look at it, there were everything which was going on, which was against the diagnosis of CDGP. This was a 16-year-old boy. Of course, there was the onset of puberty. The testes were there, and there was pubic hair development. The height was normal. So these are all against CDGP. So when we talk about that, we'll discuss about what are the pointers which go against CDGP. In this case, clearly developed and was found to have a brain tumor, which was causing these problems in that perspective. So this was a case in which we had missed the pathology. So in evaluation of puberty, which is a common scenario, 5% of all boys have delayed puberty. Physiological causes are common around 70% of cases. 30% have a pathology. What's important is that we do not do unnecessary workup in these 70% as was done in the first case, while we do not miss a pathology in the second case of 30%. This whole talk over the next 1 year, we'll discuss about the strategies about how to not do unnecessary workup while not missing on pathologies. All these resources are available in our website learning.growsociety.in, which offers a lot of resources as well as courses in pediatric endocrinology. We have our e-learning videos, so a lot of free stuff is also available over YouTube. There is option to look into our different courses, including fellowship courses in pediatric endocrinology and pediatric endocrinology for postgraduate courses as well. We frequently run grand rounds along with the PG lecture series and journal clubs to highlight these common scenarios. The books are available both online as well as the e-versions. Our app will help solve a lot of these problems. We'll try to see how it will help here. And today our focus is predominantly on delayed puberty in boys. So the option that we have is, of course, to give testosterone. That's the end organ. We give testosterone. This will work in both hypo and hypergonadotropic hypogonadism. However, there is a growing consensus, especially in the developed world, that maybe giving gonadotropins will be a more physiological way of inducing puberty in this regards. And in fact, teams in Europe have started giving gonadotropins right in the mini puberty. So if they are able to pick up hypogonadotropic hypogonadism at that age group with micropenis, maybe with multiple pituitary hormone deficiency, they do a FLH, FSH at that time, because that may theoretically help in terms of fertility. There is, however, no clear-cut evidence in terms of long-term outcome, and we have seen patients who have most severe form of Kalaman syndrome who will respond very well to gonadotropin therapy. So this is something which can be considered as a experimental therapy in that regards. There are certain GnRH pumps which are also available which use pulsatile GnRH, and there are work on kisspeptin which is going on. So the most common agent, of course, is testosterone. The one which we use most commonly is testosterone enanthate, which has to be given intramuscularly. Start off with a low dose, 50 milligram around 12-13 years of age, and then try to build up around 100 milligram. And the adult dose is 100 milligram every week, and we give it 3 weekly. It's a long-acting preparation which gives 1000 milligrams over a 12-week period. It is not recommended for pubertal induction. Its main role is once every pubertal induction is done, you want to give less frequent dosing with less fluctuation, more stable levels. Then this preparation in the form of Serenos Depot is what it's named as, is available, can be used. Gel is available, but it is having variable onset. It is not a very effective therapy for pubertal induction. Oral medications again have an issue in terms of hepatotoxicity. So what we focus mainly is to start off with this 100 milligram injections and go forward to the 1000 milligrams once things become progressive in that regards. For CDGP, we give a course of testosterone for 3 to 6 months. Usually the testicular volume increases in that regards. For permanent, we will be giving starting with 50 and then try to build it up over a 2-year period. So just like girls, where we start with around 10% of estrogen dose to build up around 2 to 3 years. Similarly, in boys, we start around roughly 15% of dose and then try to build it up over a 3-year period in that regards. Fertility is possible in hypogonadotropic hypogonadism with a combination of both LH and FSH, which could be HCG and HNG, or recombinant forms. For hypergonadotropic hypogonadism, it's less likely, extremely less likely to be more precise. If there are some sperms which are present using TISA, you can then get those sperms, extraction of sperms, and then you can use it from that regards. So hypogonadotropic hypogonadism management depends upon how the child presents to you. If there is micropenis, we give a course of testosterone 25 milligrams, 3 doses, and start puberty around induction time of 12 years. Gonadotropin have been used for fertility for quite some time, but people have also used them now for delayed puberty treatment. And as I said, in Europe, they're also using it for mini puberty as well. Remember, the use of testosterone will cause increase in pubic hair growth, but the curling of pubic hair does not happen without gonadotropin. The testicular volume increases only with gonadotropin. If a boy has an increase in testicular volume with testosterone, think of a self-limited form of delayed puberty or a reversible form of hypogonadotropic hypogonadism. So in fancy, you're mainly dealing with cryptorchidism or micropenis. You give testosterone 25 milligrams for 3 doses. Cryptorchidism surgery, as we discussed, is the treatment of choice. For self-limited delayed puberty, start at around 14 years of age and bone age of 13. Start with 50 to 100 milligram per month, 3 to 6 injections, then wait as to how things are progressing. So if you have a boy who has come to you with delayed puberty, consider treatment at around 14 years and bone age of 13. Give testosterone 100 milligram monthly for 3 doses. There is a response. You basically get that nothing much needs to be done. No response, give another course. If the testosterone levels remain above 100 on follow-up, this is a good response. However, despite second course, there is no response, you are thinking of a permanent HH. Don't be dogmatic that this is only CDGP. This cannot be permanent HH in that regards. For permanent HH, if you already know, you can start a bit early. Like in Turners, we say if you know Turners, you can start at 12, start around 12 years of age, start with a very low dose, maybe 25 to 50, because they have never received testosterone in their lives. So the only scenario in which I have seen a very severe effect of testosterone in the form of priapism is ones who had these permanent HHs, because they did not have any testosterone during their late fetal period, during their mini puberty. So if you give them testosterone, they may develop priapism. So just as we say that for severe GHD, start with low dose, for severe hypogonadotropic hypogonadism, start with a low dose of testosterone. An adult dose by around 3 years. If the testis size increases, this suggests that there could be a reversible form, and we monitor using a trough level of testosterone. You expect a phallic size increase. There is no increase in testicular volume in that perspective. And as I said, curling of pubic hair requires your gonadotropin and not just testosterone. The options of fertility are, you can use GnRH pump, which is not readily available. You can use HCG and HMG, which are surrogates for LH and FSH, and you give them for around twice a week. You expect sperm formation by 6 months, pregnancy by 12 months in approximately 70 to 80% of these cases. However, if somebody had a very early onset, complete form, and previous treatment of testosterone may have some negative implications in terms of achievement of fertility. For hypergonadotropic hypogonadism, start around 14 years and born age of 13 years. Start with testosterone, and like any other patient, you build up, look for growth, bone density, and fertility. The option could be TISA. All of you can go and have a look at our website where a lot of publications are available, our app, which will help you in terms of evaluation and management. Join our courses and look at free resources in our website.